walk through it. And for the patients, who don't really have access to someone like you, the expert, what is that process? Let's say someone come in, your surgical oncologist, your surgeon, or your dermatologist refer the patient to you. They say, okay, now the patient has, let's say, stage 4 melanomas, right? That's someone who have melanoma spread to the lung, the liver, and they come to your office. What is that consultation process like? What do you tell them?
Yeah, so there are a few very, very important things. I think, I'd love all people dealing with melanoma to know. One is that the management has to be what we call multidisciplinary, right?
Yeah,
It
totally.
can't just be one doctor taking care of everything. It has to be a team that includes medical oncology, surgical oncology, radiation oncology, dermatology. And in fact, as you know, at some of the larger centers, we have routinely these big disease management team meetings where there's a room full of specialists with pathologists, dermatopathologists, and radiologists just looking
Yep.
at the case together to try to come up with the right plan. So I think that's one key factor, kind of understanding who your team is.
Totally
Right?
agree.
I think the second piece is that the treatment of cancer is becoming increasingly personalized, right? That's true for melanoma, that's true for all cancers. And it's very important to really understand what subtype of disease you're dealing with. So for melanoma, we'll divide it into different subtypes, but one of the key things is kind of what are the molecular drivers of that melanoma. And so we'll want to understand, you'll hear these terms like, is your tumor BRAF mutated or NRAS mutated? Does it have PD-L1 expression, LAG3 expression, maybe?
Exactly.
Yeah, and so there are all these different factors that it's going to be hard to understand, but basically you want to make sure that we understand as much as possible from the tumor that was resected or biopsied. The third piece I would say is that even in cases where the melanoma has spread, our goal is still cure. And that was not the case 20 years ago. 20 years ago, our goal was to say, let's try to control the cancer for as long as we can while maintaining quality of life. Now the goal is, let's eradicate it. Let's get rid of it completely, maintain quality of life, but the goal is to get rid of the melanoma altogether, which has totally changed the way we think about treating disease. 4, and sorry this is going so long, but I hope this is helpful for the group, the audience. We need to know what kind of the standardly available treatments can be used, immunotherapy, targeted therapy. Those are really the two big choices, as well as, and I know we'll get into clinical trials, but you always want to keep in mind what are the newest therapies being tested, and do I want to think about being involved in one of those trials? Because the things that we're studying today will be the standard of care therapies that will hopefully increase that cure rate in 5 years or 10 years. And if we can access that now, maybe we should think about that.
So just to summarize, so you went through a lot. One is you need to know a team. It's a team approach. We have tumor board, etc. You need all the specialists come together to figure out a plan. Second is identifying the specific gene mutation, right? You basically have to analyze the tumor basically and to see what type of mutation you have so you can know what to act on. And third is using the two major drivers, it is immunotherapy or targeted therapy. And fourth is